Hi guys, today we will be learning a topic which is essential to apply the knowledge which we have learned from our last class. What was the last class about? It was about physiology of hearing. Now we will be applying the knowledge from physiology of hearing for the purpose of this class, that is assessment of hearing. How do you assess hearing? Since your first year onwards you have been learning to use a tuning fork, right? And we will be learning about tuning fork test, pure tone audiogram and speech audiometry today. And the most commonly used tuning fork is the Gardner-Brown tuning fork, and this Gardner-Brown tuning fork has got a base, stem, foot plate, prongs as well as a shoulder. Okay, the parts of the tuning fork won't be asked for you, but just for information's sake I'm saying. Okay, now how are we going to assess a hearing loss with the help of a tuning fork? First of all, let's analyze what are the things which we have learned. We have learned that there are three things happening when the sound is coming from the pinna, going through the axillary canal, reaching the middle ear, and from there to the inner ear, and then transduction happening in the inner ear, and finally the electrical impulses are going through the auditory nerve, right? So here there are three pathways occurring. Initially it is the conductive pathway where the sound which is getting collected by the pinna goes into the tympanic membrane, and from there into the footplate of stapes where the impedance matching is taking place within the middle ear, so that the sound gets amplified, and the amplified sound is reaching the footplate of stapes, and because of that vibration there is vibration occurring in the scala vestibuli and scala tympani, which causes a shearing action, and this shearing action is causing the movement of the hair cells over the tectorial membrane, and this movement of hair cells is causing the opening up of the various channels, and this is resulting in the release of neurotransmitters through the auditory nerve. And what is the neurotransmitter which is released? It is the glutamate, which is the excitatory neurotransmitter. Okay, so here you can see there are three pathways: the conductive pathway up to the footplate of stapes, then you have the sensory pathway after that, after where the transduction is taking place, until then you have the sensory pathway, and after the auditory nerve is started you have the neural pathway. Now the sensory plus neural pathway can be assessed by bone conduction, and for air conduction, when you are assessing it, you are assessing the all three pathways, that is conductive, sensory as well as neural pathways. Okay, and in the bone conduction pathway there is no transformer action of the middle ear, right? And that is why the air conduction is longer and heard for longer in case of the bone conduction pathway. Okay, so now coming to the various tuning fork tests. Okay, first of all we will be learning about the test, the Rinne test. Even though the Rinne test is always written first, it is actually advised to do the Weber first. Why? I will explain, but now I will be explaining to you the Rinne test. Okay, how is the Rinne test done? In Rinne test, what you are doing is you are using a vibrating tuning fork. Okay, and how do you activate the tuning fork? First of all, what you do is you hit the tuning fork over the thenar eminence, okay, so that it is activated, and the activation should be just enough to keep it into vibration, but you need not hear the sound outside. Okay, if it is a good tuning fork there won't be sound outside, and the most commonly used tuning fork is in 512 Hz. Why? Because 512 Hz tuning fork is in the speech frequency. Now what are the speech frequencies? You know that 20 to 20 kHz we can hear, right? But what is the speech frequency? Speech frequency are 0.5 kHz, 1 kHz and 2 kHz. Up to 2 kHz you can hear, that is 500 to 2000 Hz is the speech frequency. Okay, so in the speech frequency lies the 512 Hz tuning fork. The other advantages are it has got less overtones, okay, less overtones, and the decay time is optimal, okay, less overtones, and it has got optimal decay time. And of course the sound is more than the vibration sense. Vibration sense is more in case of 128 Hz tuning fork, and hence it is used for the evaluation of vibration sense, okay. For evaluation of hearing, only 256, 512 and 1024 Hz are used, okay. So why 512 Hz is preferred? Because it is within the speech frequency, one thing, and it has got less overtones, and it has got optimal decay time, and of course the sound sense is more than the vibration sense, okay. Now how will you do it to Reni's test? Reni's test can be done in two methods. One is the loudness comparison test, or and the second one is the threshold comparison test. In loudness comparison test, what is being done is, first of all, you will be keeping the tuning fork in front of the external auditory canal, about 2.5 centimeter from the external auditory canal, okay. And after keeping there, you will compare the sound heard with the sound heard while keeping on the mastoid process, okay. And then we will check if air conduction is better than bone conduction. If the sound is heard better when kept in front of the external auditory canal, it will mean air conduction is better than bone conduction, okay. And when a threshold comparison test is done, how it is done? In threshold comparison test, what you do is, you will keep on the mastoid first, and when the patient stops hearing, you will keep it in front of the external auditory canal. If he is still able to hear for some more time, that means his air conduction is more than bone conduction. Otherwise it is the bone conduction more than air conduction, okay. So this is how a Reni's test is being done. Now what are the implications of the Reni's test? When a Reni's test is done, it has got two conclusions, okay. What are they? In the Reni's test, if it is positive, it means that the air conduction is better than bone conduction. This is what is supposed to happen. So air conduction better than bone conduction means it can either be normal, or it could be due to a sensorineural hearing loss, because when there is sensorineural hearing loss, only the bone conduction is affected. There is no change in the air conduction pathway. The air conduction pathway is until the reaching up to foot plate of Stipes. So it includes the external auditory canal, the mid-ear, but there is no effect on the sensorineural pathway. So if there is sensorineural hearing loss, it means the air conduction will be more than bone conduction, okay. So these are the two implications of having Reni as positive, and when Reni is negative, it means that the air conduction is less than bone conduction, right. That is, when you are comparing with the loudness, if the loudness is less when the air conduction pathway is checked, that is when the tuning fork is kept just 2.5 centimeter from the external auditory canal in the acoustic axis in the same plane as the anatomic axis of the external auditory canal. When it is compared with the sound which is produced by keeping it over the mastoid, if it is found that the air conduction is less than bone conduction, it means Reni is negative, and that is indicative of conductive hearing loss, okay, conductive hearing loss, okay. And Reni negative can also indicate another condition. What is that? Before that, why is it conductive hearing loss? If the external auditory canal or the middle ear is getting blocked due to some condition, the problem will occur in the conductive pathway, right, until reaching the foot plate of Stipes. So it will be a conductive hearing loss. So that is why in Reni negative, that is when the bone conduction is more than air conduction, it means it is a conductive hearing loss. And there is another condition called false negative Reni, okay. False negative Reni can also occur, and that is happening in profound SNHL. Profound SNHL. What is this profound SNHL? When the hearing loss is more than 90 decibel. All that we will be learning. Okay, for now just remember that when there is severe or profound SNHL, what happens is that the patients that side here won't be hearing at all because of the profound hearing loss. But what happens is that when you are keeping the tuning fork over the mastoid, the sound will migrate to the opposite cochlea. How? By transcranial migration. Okay, the sound when kept over the mastoid will go through the cranium and reach the opposite cochlea and vibrate that cochlea, and so the patient's bone conduction will appear to be better than the air conduction, and that is what is called false negative Rini, and that is seen in profound SNHL. Okay, so when the SNHL, when it is mild, the Rini can be positive. When it is profound SNHL or even severe SNHL, it can be a false negative Rini. Okay, so these are the things that you get from a Rini's test. So how will you conclude whether it is a conductive hearing loss or a sensorineural hearing loss? Here comes the Weber's test. Okay, Weber's test is particularly helpful for this, and Weber's test is having a higher sensitivity, that is up to 5 decibel of hearing loss it can detect, whereas for Rini it needs at least 15 decibel, which can be detected by the 256 Hz tuning fork, and 30 decibel by the 512 Hz tuning fork, and up to 45 decibel only by the 1024 Hz tuning fork. So like that, by using the various tuning forks, you can have a rough idea of the hearing loss which are due to a conductive problem. Okay, that is by using the various tuning fork like 256, 512 and the 1024. Okay, so in case of which is the most sensitive tuning fork test, if the question is asked, the answer is Weber, because even 5 decibel hearing loss can be detected by the tuning fork when a Weber's test is done. What is Weber's test? In Weber's test, what is being done is, after activating the tuning fork by hitting over the olecranon or the thenar eminence, the tuning fork is kept over the mastoid or over the teeth, or it should be kept in the center. Okay, it could be kept in the glabella. Okay, any of these areas you can keep, and after keeping it over the vertex, glabella or the teeth, you will ask the patient if you are able to hear the sound to one particular side. If the Weber is lateralized to the same side as hearing loss, it means it is a conductive hearing loss, and if it is lateralized to the opposite side, it means it is a sensorineural hearing loss. Why is it so? This is because in conductive deafness, what is happening, there is something blocking the ear, right? The ear is getting blocked, and that is causing an occlusion effect. Okay, an occlusion effect is happening here, and this occlusion effect has got a lot of implications while testing for the hearing. When the ear is blocked because of the occlusion effect caused by the conductive deafness, what happens is that the tuning fork which is kept in the center, which is vibrating the whole of the skull, the vibration will be appreciated better in the ear where the conductive deafness is, because the external sound is not heard because of that blockage. Because of the conductive deafness, the external sound won't be heard. Both the cochlea will be stimulated equally by the tuning fork which is kept in the center, right? And because there is no sound coming from the surroundings in case of the ear with the conductive deafness, it will be lateralized to the same side. Otherwise, it will be lateralized to the opposite side. Okay, so this is how you find out whether it is a sensorineural hearing loss or a conductive hearing loss. Okay, you have to do a Weber's test. The next test that you have to learn is the modified Schwabach test or the absolute bone conduction test and the Schwabach test. These are for assessing the bone conduction. Okay, now how is it being done? So coming to the absolute bone conduction test or ABC. In ABC, what is being done is you are comparing the bone conduction of the examiner with that of the patient. Okay, And how is it being done? For that, first of all, you are occluding the ear canal of the patient with the help of his tragus, and then you are keeping it over his mastoid, and you ask the patient to tell when he stops hearing. When he stops hearing, it is kept over the examiner's mastoid after occluding his ear canal, and then if the examiner is unable to hear, that means the absolute bone conduction is the same as that of the examiner, and it can have two conclusions. Either it can be a normal hearing, or the patient may be having a conductive deafness, okay, or the absolute bone conduction can be reduced, that is, even after keeping it over the examiner's mastoid he is able to hear. And what does that imply? It can mean that the patient is having a sensorineural hearing loss. Okay, so there are two conclusions possible in the case of the absolute bone conduction test. One is that when the absolute bone conduction is the same as that of the examiner, it can mean normal or conductive deafness. If it is reduced, it means sensorineural hearing loss. Okay, now coming to Schwabach test. Okay, what is the Schwabach test? If you are not occluding the ear canal with the tragus and you are assessing the bone conduction by keeping over the mastoid and comparing with that of the examiner, if the bone conduction is found to be reduced, of course it will mean the patient is having a sensorineural hearing loss. If the bone conduction is the same as that of the examiner, it means he is having a normal hearing. And if the bone conduction is increased when compared to that of the examiner, that means he is having a conductive deafness. So these are the various conclusions from doing a Schwabach test. Okay, Schwabach test. Now coming to the next test, which is not that routinely done, but still it is being done. What is that? It is the Bing's test. Okay, in Bing's test also the occlusion effect is being utilized. What is being done is you occlude the ear canal of the patient and you ask him if he is hearing better. Okay, if he is able to hear better after occluding the ear canal, after you keep the vibrating tuning fork in the acoustic axis, okay, 2.5 centimeter away from the axonotory meatus, and you assess the air conduction here. Okay, and if you are able to see that the Bing's test is negative, that means there is, even after occluding the ear canal, there is no change. Okay, when you are occluding the ear canal, there is no change in the hearing. Usually when you are occluding the ear canal after keeping it near to the axonotory meatus, there will be a reduction in the hearing, right, because the air conduction will get impaired. If that air conduction is not getting impaired, that means it is a Bing's negative. So Bing's negative means there is a conductive deafness, and Bing's test positive means it could be either be normal or it could be a sensorineural hearing loss. Okay, another test which is done is a Gelli's test. These two tests are special tests which are not that commonly done but may be done. Okay, in Gelli's test, what is happening? You are using a Siegel's speculum, as you can see here. Okay, with the help of Siegel's speculum, a pneumatic otoscopy is being done. Okay, and then you change the pressure. Okay, pressure is changed over the area of the middle ear, and because of that, because of the increase in the pressure, what happens is that the ossicular chain will get fixed, and a fixed ossicular chain means the air conduction should get reduced. Okay, and if it is not getting reduced by doing a Gillies test, and it can mean only one thing: it has already been fixed, and already fixed ear canal, already fixed Sapiens foot plate is seen in the condition called otosclerosis. So Gillies test negative means otosclerosis. Okay, Gillies test is negative in case of otosclerosis. So when you do a pneumatic otoscopy with a speculum like this, okay, with a Siegel's speculum, if you are using and you are trying to increase the pressure, if there is a change in the pattern of hearing, that is the patient is unable to hear or he is hearing less. When you are doing a pneumatic otoscopy, it is supposed to be normal, or he could be having conductive or sensorineural hearing loss. If he is not having any change, Gelli negative implies the footplate of stapes is already fixed, as in otosclerosis. Okay, otosclerosis.